Welcome back to the For Your Best Self podcast. I'm Dr. Rebecca Novo, and I'm very excited about this episode, a topic near and dear to my heart. I have a special guest, Dr. Rob Novo, my husband, and we're going to talk about anesthesia today. I've been wanting to do this episode for quite some time because it's something that I often explain to patients, alleviate fears and anxieties, and make them feel comfortable about the process and the different choices that we make for surgery. And I thought a great way to do that would be to interview an anesthesiologist. Rob and I met backstory during our training in Detroit. Both of our trainings were quite comprehensive. Rob's been an anesthesiologist in Brevard for 10 years now. You just celebrated 10 years with BPA, Brevard Physician Associates, and on top of 4 years of residency. And it's quite, I can speak to it because I was there. Anesthesia is quite a comprehensive training program. We met in the ICU, meaning we were a team of doctors taking care of the sickest sick patients, cardiac patients, transplant patients, trauma patients. And of course, I have an extreme appreciation for anesthesiology, and I always have, because I can't do what I do without the support of a doctor taking care of the patient while I can focus on what I want to do, my objectives in surgery. And it's kind of a running joke that surgeons always blame anesthesia for anything going wrong. And I take the opposite stance that, like I said, I physically can't do what I want to do without the help of a team. And I think one of my favorite jokes is, this is silly, but a surgeon on a bike riding his bike, and he gets a stick stuck in his wheel spokes, and he says, "Damn it, anesthesia." So really, it's, I guess if you're in medicine, or if you're just, surgeons love to blame everything on anesthesia. But I'm pretty grateful for what they do and the scope of what they do, because your specialty is keeping the patient safe from head to toe, airway, breathing, circulation, complete hemodynamics. It's a lot of medicine and a lot of fluctuations and adrenaline, being able to think on the spot and make life-saving decisions. So welcome.
Thank you.
Anesthesia Nutshell. So a lot of the questions that I have with patients are about the types of anesthesia and what is that like, and that maybe they've had a past bad experience with nausea or pain or a fear that they're going to be awake. So we're going to go through the basic types of anesthesia as sort of an educational resource for patients. We're kind of building this library, and it's been really nice for our staff and our teammates and our patients to say, hey, go listen to this kind of in private and take it in at your own pace. And so I thought it would be helpful to have a resource on anesthesia. So thank you.
You're welcome.
So in general, the basic types of anesthesia, we'll do local anesthesia in the office. That's pretty much the extent of what we do. That's our comfort level, our setup. And there's varying levels that we'll get into, like sedation and general anesthesia, which are more in the hospital or surgery center setting. So how would you best describe local injections, local anesthesias, anything we can do with numbing medicine, basically?
Yeah, that's the easiest way to explain it. Local anesthetics, there's pretty much just only two types, esters and amides. And
we'll try not to nerd out.
Yeah, we'll try not to nerd out.
We won't go too deep.
Everybody knows lidocaine. And lidocaine's a short-acting numbing medicine. It's usually what you'd get at the dentist office. And
last about a couple hours.
Right, a couple hours. Bupivacaine or Marcaine is what you'd probably see the surgeon more inject you with, even in the office or in the OR. And that should get you about 6, maybe 8 hours.
Slower onset, but longer lasting.
Correct, yeah. So Marcaine usually works really well, especially if you're giving an IV sedation, keeping the patient comfortable another way, because then you could have a slower onset, but then you have better benefit, or postoperative analgesia is what we call it. So analgesia is the lack of pain or inability to sense
everybody's
pain.
goal.
Right. And that's pretty much local anesthesia. Local anesthesia is really good at numbing certain areas, and it works even better as an adjunct therapy for surgical cases, whether the patient's awake or whether the patient's receiving general anesthesia, sedation. Something else.
You do a lot of nerve blocks. It's one of your specialty, and we do some of that in the office. If we're doing things on the face, we might target specific nerves.
Right.
So if you could touch on that, nerve blocks.
Yeah, a nerve block, basically what we can achieve with a nerve block is, say, that 6 to 8 hours that we were talking about with some of the medicines that we use. Now we can achieve over 12 hours, close to 24 hours of pain relief, because what we're doing with a peripheral nerve block is we're numbing up very accurately a nerve bundle or some basically areas where nerves run through. So by bathing the nerves with this medicine, it doesn't actually go into a nerve. So that's the big misconception is, and we're not putting anything in a nerve or in a spine or anything like that. Putting it near it, creating a pool.
The neighborhood.
Yeah, putting in the neighborhood, but it's a real accurate neighborhood so that you can see where it's going, and then you get a real longer duration. All these medicines work the same. They're blocking sodium channels, and these sodium channels are real important they're the gatekeepers of letting the brain sense pain. So the longer that you can block these, or the slower that they become unblocked, is how you get better pain relief.
So you do a lot of that for ortho joints and things like that, or we would do that in the face for sensory nerves, really,
yeah.
That give you feeling, not motor control or muscular control. So I think that's important to distinguish. So that's commonly what we're doing in the office. We do a lot of skin cancers, blepharoplasties, biopsies, things like that, where you're going to get, other than the bee sting or the very fine needle poke, you're really going to not feel anything other than pressure. So once you get past the numbing point, patients are super comfortable, and then afterwards for those procedures, we'd usually just have you ice or take Tylenol. Rarely anything we're doing under local needs, anything stronger for pain control. And so the next level up, which we currently don't offer in the office, but might be in a surgery center, or you might have experienced it with your colonoscopy if you've had one, or a lighter procedure would be twilight or IV sedation. Could you explain what that process is like a little bit?
So it can range actually from twilight. So IV sedation can range from twilight to general anesthesia, essentially.
IV sedation, meaning you're just getting medication through an IV.
Right. So there's no breathing tube involved, and typically this works really well for procedures that are not, actually not causing pain, not surgical or causing any incisions. So a colonoscopy is a really good one. Some lighter procedures where a local anesthetic can do most of the work for you as far as pain relief goes, you can do an IV sedation.
So it really affects awareness.
Right.
And you would still need to use local anesthesia for pain.
Yeah. And because there's a level because there's a level between twilight and general anesthesia, twilight being that if I called your name, you would be able to respond to me, or if I called your name but you couldn't respond to me, but say I shook your shoulder or something like that, then you can respond, then all the way up until unconsciousness. And so that's where really the balancing act of the expertise of an anesthesiologist or an anesthesia team is involved, is that maintaining unconsciousness or or taking out away the awareness, but doing it in a safe way. And that's typically a lot of the questions that we get involving that Michael Jackson case, where you're receiving propofol just like we do every day.
Propofol got a bad rap during that time, or there's a lot of fear associated, but like you said, the advancement is in monitoring. Yeah,
so monitoring is really where anesthesiology has shined in the last, I'd say it was the biggest turning point was probably in the late 80s or mid 80s, where some of the monitors really improved, and all the way up until now, some of the monitors and the technology that we have to keep patients safe is drastically improved.
The type of things that you're looking at,
yeah,
other than oxygen level.
Other than oxygen level, we're of course blood pressure. We can now even tell the depth of anesthesia, and there's a couple of ways that we can tell that, and that's either with our ventilator. We also have these little, for lack of a better word, headband that we use that'll tell us how asleep you are. It's basically like a real-time EEG. So if anyone ever had an EEG before, it's, you know,
brainwaves.
Brainwaves.
Measuring brainwaves.
Measure brainwaves.
Or activity.
And we're basically just using a number on a number scale how asleep you are. So these are all big advancements, and you know, a lot of the times it's not necessary for every type of surgery, and you know, every patient's different, but we do have an incredible arsenal these days to keep patients safe.
So if I was going under IV sedation, some important things that you'd want to ask your doctor and make sure that you had some monitoring.
Right,
or that someone was there capable of. You probably wouldn't be a candidate for that if you had sleep apnea or morbidly obese, or if you have a compromised heavy airway. And
that's why an anesthesiologist, a physician anesthesiologist, is very important in the anesthesia team. Now, of course, you can have just a doctor. You can sometimes have an extender, an anesthetist with you, but having an anesthesiologist makes those critical decisions whether a patient's appropriate for a certain facility, depending on the resources. So you're not only just, you know, giving a medicine, but you're also taking into account the patient's physiology, the patient's medical history, and as well as you have to think into the future, what am I going to do if this, and then if this, what will I do then next? So that's a lot of what we are not only focused on, but also trying to be prepared for later.
Right. So somewhat alluding to like ASA class, or when we talk about comorbidities, like how many illnesses does this patient have? Is it safe to do even at an outpatient surgery center, or is this someone who really should be in a hospital where there's a capacity to admit them, or even an ICU if needed, or other specialists available? So I think that's a huge underestimated value, is when you have someone that's kind of making the safest decision of where this procedure should happen and what resources are available for worst case scenario.
The ASA score is a score based on, 1 through 4 essentially, or 1 through 5, however you want to really call it, but it's basically using different comorbidities and
which means diseases
and how those diseases affect the individual, and we give them a number, and basically that number tells us how at risk they are for certain types of procedures and certain types of anesthetics, and that's one of the ways that because the anesthesiologist has to take into account not only the medical history of the patient, and we have about very little time to do so it becomes very important to not only be honest with your anesthesiologist, but if for some reason the anesthesiologist doesn't ask you a question that you think may be pertinent to your history or maybe pertinent to your anesthetic plan, then definitely go ahead and offer it. And I think that's something that all patients should be empowered to do.
There's no benefit to anyone to deny you're a smoker or high blood pressure, blood thinners. All these things become really essential in decision making for safety. Yeah. And a lot of times just the better overall picture you can get about a patient, the better the outcome will be. We use also, and it's not just history, but what kind of medications you've been on and for how long you've been on them, because that can change what tolerances you may have built up to other medicines, and we use toxicities.
Exactly, toxicities as well. So we use that all and kind of mix it up into our plan.
So the next level of anesthesia we use most commonly would be the general anesthesia category, and this is usually when there's some level of airway protection. The main two, I'll let you get into the details, but I typically use, disclaimer, I don't we don't work together because I'm in an outpatient surgery center. Rob works at almost all the Health First facilities. So this is unbiased.
It's unbiased. We haven't worked together in a long time.
Since training, yeah. But so for general anesthesia, there's a LMA, or I kind of describe it to patients. There's going to be a sponge mask in the back of your throat. Am I explaining that correctly? Versus the endotracheal tube, which goes through your vocal cords and into your trachea. And then it really, my algorithm is, with discussion with the anesthesiologist, is if I need muscle relaxation, it's going to be endotracheal, because then by delivering muscle relaxation, the lungs need support.
Yeah. And that's a very surgeon perspective to explain it, because the surgeon
That's so surgeon-y.
That's very surgeon-y. If I need muscle relaxation, I want an endotracheal tube. So a lot of times
okay, what's the truth?
The real truth is that general anesthesia is a lot safer than what most people expect. A lot of people come in asking,
this is the myth buster.
This is the myth. Yeah. Most people say, well, can I just have sedation for this procedure? And actually, sedation can sometimes be a much more involved balancing act than general anesthesia. General anesthesia is very safe and secure.
It's more predictable.
It's
right?
more predictable. It's the equivalent of flying on a plane with a pilot rather than jumping off a cliff with a hang glider. You could probably achieve a pretty good height and cover some ground, but your landing's going to be much more comfortable with a pilot. The endotracheal tube versus an LMA really not only has to rely on whether the surgeon needs muscle relaxation, but also certain patients won't tolerate an LMA, or their anatomy won't tolerate an LMA. Also, a secured airway is what we call an endotracheal tube, is the best route sometimes. And that can also just be dependent on if the surgeon is working near the eyes, the face, near the mouth, and we don't really have access to that area, so we will want to have a very secure airway, and that is an endotracheal tube. So,
because you have to think about the airway is in direct continuity with your gastrointestinal tract secretions, saliva, reflux, anything that could go in or out of the stomach, esophagus.
Yeah, and that's what we don't want. So we
could be at risk to go into the airway. So ultimately, the endotracheal tube is separating that potential connection, so you can't aspirate.
Yeah, correct.
Or have dangerous things go into your breathing.
Yeah, and that's and again, that's probably the main reason we use one versus the other.
Sometimes it's duration of the case.
And sometimes it's the level of maybe pain or stimulation that you're expecting during the case will also have us choose an endotracheal tube versus an LMA. But both can achieve unconsciousness.
Right.
Both will achieve unconsciousness. The only difference is kind of the device.
Yeah, a lot of, I don't want to say it's pushed back, but a lot of patients, they want this kind of simple in the office procedure, and it really is my job to explain to them, oftentimes the safest, most controlled setting is going to give you the best result, right? So, and it's also just part of my philosophy as a surgeon, and every surgeon has their different comfort levels, but I want to be focused on the procedure. I don't want to be thinking about, give them more pain meds, or how's their heart, how is their hemodynamics going, or.
And that's why it's important to have another doctor, an anesthesiologist, involved in your care, because then the surgeon can focus on what they need to do, and that you're in the hands of somebody who is trained to just
that's their sole focus.
Yeah, correct. I mean, of course, I shouldn't say I should assume this, but we do still sometimes get questions like, is an anesthesiologist like a doctor? And actually, an anesthesiologist is a doctor. We went to medical school 4 years, and then our residency which residency out of medical school can vary anywhere from 3 to 5+ years, just depending on what you choose. Anesthesia is a 4-year residency. And then beyond that, we can do fellowships, just like, there's a plastic surgery fellowship. Peds,
heart.
But in our case, it's usually pediatrics.
There's a plastic surgery fellowship?
No, I'm just saying a surgeon plastic.
I was like, interesting.
No, there's peds, OB, neuro, pain management, regional, critical care.
Yeah.
Because anesthesiologists are critical care physicians. We're the experts of the airway.
Hemodynamics.
We are sometimes called upon in the hospitals in order to secure airways. It's definitely something that our role has become even more so called upon lately with our COVID surges. And actually, my group has currently been called upon to take care of certain COVID ICU patients because of airway, hemodynamics, ventilatory settings, which are managing how a breathing machine works on your lungs and how your lungs respond to a breathing machine.
Mm-hmm.
And so these are all things that anesthesiologists are trained to do. It's just that, of course, now we're finding a new role.
Well, I have a lot of respect for what you do, and it's not just because I'm married to you. I feel like I've always been humbled by your profession. So touching on another topic that a lot of patients fears or anxiety is nausea post-op. So what are some nuances to minimizing nausea, advice you'd give to patients, or techniques you use if I have a history of nausea and I don't want to wake up vomiting after my procedure?
Well, number one is if you have a history of being nauseous after surgery or anesthesia, definitely always mention that. There are some medicines that we use that help prevent that, and sometimes it has to do with the timing of when we give those medicines. Some of these medicines, probably the most common one that you hear of is Zofran or Dancentron, is not very effective once you're already vomiting. Most people don't know that, but actually, typically you want to give that 30 minutes prior to when you would expect the patient to be nauseous, which is sometimes right afterwards. Mm. And there are some other medicines that we use that are a little bit longer acting that we can give preemptively that can bridge that gap from when you leave the surgery center to your next day at home. Mm. And other ways overall that we're trying to prevent nausea with anesthesia is we use what's called a multimodal pain management technique, which is not just using opioid narcotics, and the opioids are anything that's based off of morphine. So morphine's the grandfather drug, and you've got anything from as light as codeine all the way as strong as fentanyl, remifentanil, and sufentanil. These are all synthetics branched off of the morphine. So these are the ones that really cause the nausea typically. And the less or the better balance that you can achieve with giving opioids to the patient's needs, but then also using other medicines. Now, in the case of plastic surgery, we stay away from anti-inflammatories, and that's not just in plastic surgery, but also in other surgeries where you're in a sensitive blood vessel area and you want to minimize bleeding. Anti-inflammatories are the ibuprofen type medicines, and in our case, we use Toradol, which is very similar to that, and those can increase your risk of bleeding. So we'll use Tylenols. We'll actually use like a higher dose Tylenol.
There is IV Tylenol, which works great. Mm-hmm. It's expensive,
great,
so not everybody has access to it. But
we also use muscle relaxants, like Robaxin is a typical one that we'll use in the hospital a lot. And most commonly, or not, I shouldn't say most commonly, but what we really get the best outcomes with are with any local anesthetics, whether it could be surgeon injected local anesthetic in the field or peripheral nerve blocks like we're doing for some of our orthopedic surgeries. And
I've noticed the use of Exparel. Like, I rarely have to give more than Tylenol with codeine, which is a pretty wimpy but using Exparel, which is long-lasting bupivacaine or liposomal bupivacaine, meaning it's that local anesthetic, but they made it in a fat cell so that it stays longer locally. Patients have been really happy with that, mainly in tummy tucks or breast dogs, things like that.
Yeah, anything where you can let the local anesthetic do a
More
bulk of the
work.
work is a good thing.
Decreasing your requirement for opioids, leading to less nausea.
Yeah, and I think
Is
also,
hydration helpful?
hydration is helpful to an extent, but I find that hydration is a little bit more helpful in the case of nausea than it is of. Nausea maybe more pre-op than post-op,
Okay.
not necessarily post-op, but also a thing that we'll do with the local anesthetics is we'll also kind of set expectations as far as preoperatively what the patient can expect. Like, you will receive this kind of numbing medicine. This is the amount of time that you could expect relief from it, or this is the goal range. And then to also, start a regimen as far as when to start taking your first pain pill. That way, staying ahead of the pain is usually what I call it, is an important aspect of being comfortable the next day.
Not getting those peaks and valleys, just being a little bit consistent with it.
And if you have an opioid type pain medicine, you could also alternate it with a Tylenol. A lot of times I will say, go ahead. If your Tylenol is saying, depending on their strength, 4 hours, then go ahead and take that every 4 hours, and then 2 hours later take the other medicine you got.
We just forewarn patients not to take more than 3 grams of Tylenol in 24 hours because of liver toxicity. So just something to monitor if you're taking Tylenol plus codeine with Tylenol or something like that. And then some doctors are using gabapentin or things like that preoperatively to decrease post-op pain.
Yeah, and gabapentin and Lyrica is another common one, are used to basically kind of help with that nerve pain. And when I say nerve pain, I'm kind of more talking about that burning type sensation. These medicines work real well for that sort of thing.
Any comments, since there's so much CBD's everywhere, right? It's in lotion, it's everywhere. Any comments? I know we carry a soft gel in our office currently. It's not something I've proactively integrated into the practice, my personal patient practice, but are you seeing that trend?
We do see that trend as far as more patients coming in on
some form of it.
I would definitely urge all the listeners to go ahead and do your research on this. And most of the papers that are coming out right now on CBD, and remember, there's two. When you're talking about CBD and marijuana and THC, there's different things you have to understand. Is that marijuana obviously is a plant. THC is the extracted psychoactive substance that causes the highness. CBD typically does not cause any of those high side effects, but there are some. They're starting to show that there are some analgesic effects of CBD. However, the big misconception is that although it is legal in this country, there is no FDA approved CBD medicine currently. So
a little monitoring or regulation and amounts.
Well,
effect.
not only amounts and effect, but also the preservatives, how these are kept. This is all really important until we can get a better understanding of what it's doing and what the effects are. I think we'll see some things in the next few years, but I think once we have a FDA approval, we'll have much better, closer monitored studies that are more reliable.
So maybe stronger for kind of baseline anxiety versus true pain control at this point.
Yeah, I would say that again with a little caution, because there have been some studies that have shown that it actually can have a paradoxical effect, or what we call a kind of an opposite effect on anxiety, and can kind of ramp you up a little bit more. Usually what we use for anxiety in the perioperative setting is are the benzodiazepines. So
that's my patient's favorite part.
Right, yeah.
They're all nervous coming into surgery. I'm like, don't worry. They're going to give you something. Just let's talk, do the paperwork, consent, and then you'll get something that's going to make you not care.
Right. You want to sign all the paperwork before you get that. Because, so these are medicines like Valium, and typically what we use is called Versed. It's just an IV form. They have a little bit longer acting profile. But these medicines not only have a great anxiolytic effect, or the ability to kind of take away some of that anxiety, but they also have this desired side effect of what we call retrograde amnesia, which is knocking out a little bit of that short-term memory, which is nice. So you don't remember the bright lights and the all the people talking to you and things like that. So
yeah, I would say most patients are like, their first response is, it's over. I don't remember anything, or I cannot believe my procedure's already over, even if it was 3 to 5 hours long. It's just...
Yeah, anesthesia can be the best time travel you ever got.
Anything else you think we should cover?
I think a good resource is asahq.org. That's American Society of Anesthesiology. That's our website, and you can get much more detailed information there, and that's a good resource to have. And again, we're all board certified physicians, and it's good to ask that. It's good to know what the difference is. But again, doing your homework is always encouraged.
Yeah. And I think it's important too to understand how rigorous the training is too. You guys do everything from trauma to burn to the full gamut of emergency and
we do all these crazy things, then we just hang out with fancy plastic surgeons.
And we also have some of this in summary in a recent blog that we co-wrote, which is on our website too. So thank you for being here. This was really fun.
You're welcome. Thank you for having me.
Sorry it's not about surfing or foiling. You could probably talk for 20 hours on that. Those are Rob's other... I joke that he's a professional surfer sponsored by Anesthesia.
Yeah.
Well, thank you. Again, check us out. Our website is www.foryourbestself.com. If you like this, share it, subscribe. It's pretty exciting that our audience is growing. I think we surpassed 2,500 listens all over the world. And so share it, pass along, subscribe, and let us know what else you'd like to hear about. All right, till next time.